Good evening, everybody. I'm Alastair Burt. I'm the Executive Dean of the Faculty of Health Sciences. I'd like to start by acknowledging the Kaurna people, the original custodians of the Adelaide Plains and the land on which the university campuses here at North Terrace, Waite, Theberton and Roseworthy are built. So it gives me great pleasure to welcome you all to this evening's Executive Dean's Public Lectures. We have a number of these throughout the year, as some of you know. Thank you for joining us. It's a particular pleasure to welcome Professor Hans van Delden, who's in Adelaide in part to explore collaborations with academics in our School of Public Health. Hans is a Professor of Medical Ethics in the Medical School at Utrecht University in the Netherlands, and is also the Director of Education at the Julius Center for Health Sciences and Primary Care. He's been a long-time active medical practitioner as a physician working in the aged care sector for over 25 years. So ever since working as a house officer in an intensive care ward in the Netherlands, he's had a very keen interest in medical ethics. He completed a thesis on the medical and ethical aspects of Do Not Resuscitate orders, and was one of the principal researchers of the study of medical decisions concerning the end of life for the Remmelink Committee. As Chair of Medical Ethics at Utrecht, he's established a highly regarded academic group. Their fields of interest include research ethics, moral problems at the end of life, and moral problems in the care of the elderly. He's currently chair of the International Bioethics Committee at UNESCO and president of the Council for International Organizations of Medical Sciences. He's published extensively in his area of expertise, including in some of the highest ranking journals such as The Lancet, New England Journal and so on. So tonight he's going to discuss the euthanasia law that came into effect in 2002 in the Netherlands and the way that societal control around this is shaped. So without further ado, I'm delighted to introduce Hans van Delden. Hans.
Well, thank you for that very generous introduction. And thank you for being here, and thank you for inviting me and for making it possible to hold this lecture. I'm going to disappoint most of you, I guess, because I'm not going to persuade any of you to change your mind or to change your view. I'm not going to convert you to become a pro-euthanasia activist, or I'm not going to convert you to become totally against it. My goal is actually to give some insights into what's happening in the Netherlands. I think we're the only country that has so many data on its end-of-life practice. And of course I know that data are never value-free. I'm not claiming that. At the same time, I do think there are lots of misunderstandings going around when people talk about the Netherlands and euthanasia, and I think it would be very helpful, and therefore I'm really also grateful to show you the data as we read them and as we interpret them. And I also would like to make some remarks on the developments that have gone on since the introduction of the euthanasia law in the Netherlands in 2002. Before I say more, I should acknowledge that, of course, the data that I'm presenting are certainly not my own work in the sense that I've done that on my own. There's a list of people there. You'll find my name somewhere. And so most data that I present are actually taken from this publication, and I'll tell you later why it wasn't a more recent one, but I'll get to that. It would be good, I guess, to give you a few insights into the Netherlands as such. The Netherlands is a really tiny, as tiny you can get country. I've figured out that South Australia is 26 times as big as the Netherlands, but we have 10 times as many inhabitants. So you can figure out the density of the population, right? We do not have a system of National Health Service, as I understood you have. We do have a system in which there is a compulsory, I put obligatory, but I think it's compulsory, that's better English, I guess. But anyway, so there's compulsory health insurance, which is the first tier, which is very generous. And then you can, if you want to be completely insured, you can, of course, buy into more insurance. All in all, I would say there's good general access. Of course, all of this is there to take away the idea that people in the Netherlands ask for euthanasia because of lack of care, right? I mean, that's why I give this background, because it's not out of lack of care that they ask for euthanasia. It's for different reasons, and we'll get to that, of course. There's full coverage of terminal and palliative care. We have a system that doesn't rely that much on hospices when it comes to palliative care. Of course, I'm familiar with the English model, in which people tend to think that palliative care is something that you can only do in hospices. Well, we disagree. We do have hospices, and we do think they have an important place. If you would know that only 10 years ago we would have maybe 14 instead of 140, you can see that indeed the number of hospices has risen dramatically over the last years as well. But we do not rely on that system alone when it comes to palliative care. Let's say the backbone of our healthcare system really is the GP, is the general practitioner, and the general practitioner is also able and is trained also in palliative care. So palliative care will be also supplied through the general practitioner, and indeed also through hospital doctors. But really, GPs, general practitioners, are the backbone of our healthcare system, also when it comes to palliative care. It might also be good to know, I didn't put all of that, and I should slow down maybe because I'm talking too quickly, right? Okay. Anyway, it's also good to know that people in the Netherlands want to die at home. That is, if they want to die, if they know that they are going to die somewhere, they prefer dying at home. So, yeah, more than half of people die at home, and again, the GPs will be the ones who are providing care to them. So you can see that it's really the GPs that take a good share of palliative care. There's a structure with palliative consultation teams. There's probably not a word on any of these slides that I could not talk an hour about. I will not do so because I only have 45 minutes. But of course, if anything of interest strikes you, then we could get back to that subject in the Q&A afterwards. Well, this is one of these slides that I really could talk more than an hour about. This is a small summary of the history. You can also see that I'm not very good in making these slides because this bar shouldn't be there, but I couldn't get rid of it. So it doesn't mean that we all of a sudden stop developing palliative care. You might get that idea from it, right? So please ignore that bar. But the point is that when it comes to the euthanasia law, well, I think it's fair to say that you could start in 1985 when there was a state committee that also redefined the term euthanasia. I'll get to that in a minute. And they really suggested that euthanasia should be allowed under specific conditions. So they were the first to actually advise the government to decriminalize euthanasia. Then a new government came, and they didn't really know what to do with the subject of euthanasia. And of course, I'm perfectly sure that here in South Australia this works differently. But in the Netherlands, whenever you have a political problem, you create a committee. So a committee was created, and that was chaired by Professor Remmelink, a famous Dutch lawyer at that moment, professor of criminal law, a highly regarded person. And of course, he knew everything about criminal law, but not so much about doing research. So someone else had to do that, and I was part of the group who was invited to do that. And that's how my career started, actually. So we collected this information on the practice of euthanasia and other end-of-life decisions. And maybe already there I should point to the fact that phrase, euthanasia and other end-of-life decisions, may need some explanation, because we, after 1985, used euthanasia in a very specific way, meaning only death on request by the patient, of course, and administered by someone else. I'll get to that again shortly. But so we had to introduce a new concept, and end-of-life decision-making was our new concept as an umbrella term to allow for other decision-making that, ethically speaking, sometimes gets very close to euthanasia, as in stopping and not starting with treatment. Okay, so and there's a whole series of studies, and then there was a political response to the study, and something new was created, and of course we had to study it again, which was only good for us, of course. And so there was a back and forth between, let's say, studies and empirical work on the one hand, and governmental and let's say, political responses on the other hand. A number of these studies emerged from that situation, but after 2002 the Euthanasia Act was enacted, and no one in The Hague remembers this slide, so they now think that every 5 years you have to have a nationwide study, and of course we let them believe this. So, and it's getting really close to the reality. And so 2005 we had a new study, 2010 again, but this time, and you can see that from the slide, without a change in the political or the governmental or the, let's say, the governance structure of euthanasia. So the back and forth has stopped after 2002 in a way. And indeed in 2015 we had our 6th round, but that data is not available yet, so I cannot talk about those data. We expect to publish in 2017, and that's why I quoted the article from 2010, because those are the latest publicly available data. Right. Again, much more could be said, but maybe if it's of interest to you, we can return to that subject later after my presentation. Definitions I already talked a little bit about. Of course, I'm aware of the fact that in many countries euthanasia in itself is an umbrella concept, and you have to start adding words like passive or active or all that. In the Netherlands, euthanasia means active, direct, and on request. That's euthanasia in the Netherlands. And then there's also physician-assisted suicide, and the difference is really the person who acted last. So if it's the physician, we will call it euthanasia. If it's the patient who took a lethal, swallowed a lethal drug, then we will call it physician-assisted suicide. So it's really a technical difference between the two, which in itself is an interesting topic. I could go on talking another hour about that one. Because indeed, in some countries, people will say this is a huge difference. Euthanasia is something which, I mean, it may be on request, but it's killing another person, and therefore it's much more difficult, ethically speaking, to justify than physician-assisted suicide, where, let's say, the onus of the justification is on the person, him or herself, who decides that he or she wants to die, but would like to have some help, and finds a physician who is prepared to do so. In the Netherlands, physician-assisted suicide and euthanasia are seen as two of a kind. The so-called euthanasia law, which of course in Dutch doesn't really, it's not the official name, but let's call it the euthanasia law, really applies to both of these. So whenever I talk about the euthanasia law, I actually also mean physician-assisted suicide. For us, it's two of a kind, and it's really sort of reduced to almost a technical difference. Again, something you may want to speak about, whether or not this was fortunate. Some will argue there are huge differences in ethical appreciation that are now overlooked, but this is the situation we have in the Netherlands. So, and this is fairly easy, I would say, euthanasia is not ending of life without a request, of course not, because it was on request, direct and active. That's what I said, right? Alleviation of symptoms with hastening of death as a side effect. Let's say the classical use of morphine is not euthanasia, is not regarded as such. Palliative sedation, if applied under the conditions that apply, is not regarded as a euthanasia, and the same applies to withholding or withdrawal and potentially life-sustaining treatment. If someone in an intensive care unit would stop a person and would withdraw that person from a ventilator, then that would be seen as something else than euthanasia. Of course, rules would apply, but not the euthanasia law. I'm telling you this because otherwise you cannot sort of interpret the numbers that I'm giving you. And by now you have noticed that I always talk ahead of my slides. So this is something that indeed I said earlier. For us, end-of-life decision-making is all of that. So that's the new umbrella concept with euthanasia and assisted suicide. I've abbreviated that into E/AS, which means euthanasia or assisted suicide, is just a part of that. And of course, morally speaking, a very significant part, and maybe the most problematic part. Well, maybe not even the most problematic. I think the first bullet is even more problematic. But anyhow, end-of-life decision-making is the umbrella term. Maybe we should also go into why we think, indeed, there should be an umbrella term for all these decisions. But again, that may be something to touch on after the discussion. Now, historically speaking, it would have been more appropriate to first give you the first two, or actually three, rounds of empirical data, and then give you the law, because that's the historical order in which they appeared. But I think actually it's better to approach the data with some understanding of the Dutch law. And the Dutch law says that euthanasia and assisted suicide are forbidden. Full stop. Please hear me right. Forbidden. Unless a doctor performs it who sticks to the criteria for due care and reports to a committee. So if you're not a doctor, there is no legal provision that would allow you to perform euthanasia or assisted suicide. This only is applied, or is possible, for doctors. And that is also why you can understand that the law specifically addresses doctors. The law actually does not address patients. The law addresses doctors and says, well, the doctor has to be convinced that the patient has made a voluntary and well-considered request, that the patient was suffering unbearably and that there was no prospect for improvement, that the patient was well informed and knew his situation and the possibilities and, let's say, the alternatives, and indeed that the doctor, together with the patient, came to the conclusion that there was no reasonable solution to relieve suffering. And then there are two more, let's say, formal criteria, that all of this needs to be checked by an independent physician who really visits the patient and writes a report. So not just over the telephone, but visit the patient, talk to the patient. And then also, let's say, performing this has to be done with due care. Now, maybe just to say a few more words about this list. If you look at it, really, 1 and 3 are connected. I guess you agree with me there. Because how could you be, let's say, a voluntary and well-considered request, how could you do that without being well-informed, right? So 3, to a certain extent, is already embedded in 1. And to a certain extent, the same goes for 2 and 4. Because suffering unbearably is taken to be something of the patient, in the sense of an evaluation made by the patient. If I'm suffering unbearably, then that's really for me to say. Although a certain, let's say, intersubjectivity should be there. If I would now tell you that I'm right now suffering unbearably, probably you would say, no, I don't believe you. You seem to be enjoying lecturing, and that's true. So probably you would not really believe me, right? And that's the kind of check that a doctor should also have. A doctor should really check whether the patient is, whether it's reasonable to claim that you're suffering unbearably. But the other part of that phrase, with no prospect of improvement, is actually taken to be a medical judgment. It's taken to be a medical judgment whether or not you can do anything about that suffering. If a patient says, I'm suffering unbearably, the doctor says, well, I got a medicine, then that second criteria would not apply. And so in a way, 4 is repeating 2, because it says there is no reasonable other solution to the situation the patient is in. So again, 4 is really, to a certain extent, a reiteration of 2. There's so much more to say, but when we first started with the reviewing committees was actually before the law. And that was the first time that we really had to have a sort of a framework. Before that, we had to rely on jurisprudence, case law only. In 1998, the first review committees were installed, and it was only after that moment that a framework was really there. And at that time, 3 and 4 didn't exist. So the framework we had in 1998 was actually 1, 2, 5 and 6. And 3 and 4 were added out of political discussion, and they're, I mean, okay, it's not bad that they're there, but they're really sort of repeating what was already in 1 and 2. And then of course 5 is that there has to be an independent physician who evaluates the case by him or herself and comes to the same conclusion, and it has to be performed with due care. My point in all of this is that you can really see that euthanasia and physician-assisted suicide in the Netherlands is something that is not determined only by the patient, but also by the physician. So in a way, I mean, let's say the classical situation that people used to think or used to have in their heads was a patient who of course was diagnosed with something very terrible, tried and palliative care was applied, but somehow it didn't work, and ended up in a situation in which the patient said, I really cannot do anything, I cannot tolerate this anymore, and the physician was saying, and I really don't have something to make your life any better or to relieve your suffering in a let's say in a sufficient way. And so in that situation they both would have evaluated the situation from their perspective and jointly would have reached the conclusion that indeed maybe to respond positively to the request of that patient for euthanasia was the least of two evils. That's the classical situation. That's where we come from. That is where the jurisprudence was based on, and that's also what sort of is the spirit of the law. Although formally speaking, let's say the rule of necessity, which is a legal idea, is no longer there. Still, let's say ethically speaking, there was this idea that indeed maybe, because the doctor has two obligations, right? One is to preserve life, also in the Netherlands. Don't get me wrong. Doctors in the Netherlands have an obligation to preserve life, of course. But at the same time, they also have a duty to relieve suffering. And there might be situations, that was the thought, that indeed maybe the relief of suffering could be seen as the stronger obligation, and therefore in such and such situation a physician would be permitted to to fulfill the request for euthanasia by that very same patient. That was the thinking, and of course I'm building this case to show you what has changed, because later on I think we'll find something different. Well, something that would require yet another hour. By the way, it's 12 o'clock now before we can leave this room again. So yet another thing is the fact that in that same euthanasia law, a provision is given that a written directive, an advance directive, would count as a request for euthanasia or assisted suicide. Well, probably not assisted suicide, so euthanasia. And therefore a physician may follow this directive provided that all other criteria are met in a corresponding way. And of course that has opened the discussion about dementia and patients with dementia, whether or not they could in advance write a directive stating that if I become such and such due to dementia, and maybe at that moment I can no longer repeat my request, then please regard this piece of paper as my request, and if all other criteria are met, please fulfill my request. Again, maybe something that we need to return to later after the presentation. So really shortly on let's say the empirical work, that is the basis for the empirical work. What's important to know is that we did not use the word euthanasia in our survey. We asked what doctors did. Did you supply a drug with the intent to end life on request of a patient? If they said yes, they would end up in our ordering as euthanasia. But we didn't say, did you commit euthanasia? Because some doctors may not have the same understanding, certainly not in 1990, as let's say people now have. So we didn't use that word, but we tried to be as factual as possible. Did you provide a drug on the request, the specific request of the patient, with the intent to end life? If they said yes, we would count it as a case of euthanasia. We sent questionnaires to doctors who reported to Statistics Netherlands, a death, and there is an obligation probably here as well, right? If you are the attending physician of someone who dies, you have to fill in two forms. One, telling the municipality that the person died, and second one, telling Statistics Australia probably, or South Australia, that the person died of such and such causes, because then people can keep track of of the epidemiology of disease. So we send a questionnaire to all reporting physicians, reporting of a death, and ask, what did you do? The questions and some more, of course, that I just told you about. And the good thing is that we really got a strong response rate. I mean, in terms of, let's say, a written questionnaire, these are really response rates that you can only dream of, and it's really impossible to get that higher on written questionnaires. I mean, nowadays you sometimes have 30% or something like that on written questionnaires, and this is really good. And we had a quite good number of questionnaires in our survey, so we feel that we have a strong empirical basis for our numbers. Of course, we're not claiming that we have the absolute truth or something, but we do feel that we have a strong basis for the numbers that I'm going to present to you. Just out of interest, our annual death rate is approximately 140,000 people per year, and 30% of that is cancer related. So here are the first numbers, and when I show these numbers to medical students, I always ask, what strikes you most? I figure I won't have the time to do that right now and here, but I mean, something that's clearly striking immediately is the indeed very low number of cases of assisted suicide as opposed to euthanasia. When I first entered this area, this theme, so in the 1990 study, we made some predictions. We didn't know. We made predictions and said, well, what do you think? Will it be more euthanasia or more assisted suicide? And we all predicted more assisted suicide, because that felt to be closer to the fact that this is an autonomy-based thing. And we were really stunned to see that that it was the reverse. And actually, it's getting more diverse, so that there's even proportionately less assisted suicide now than there was before. What's also interesting to see is this lower frequency in 2005, and of course some of that will be explained by the fact that in 2002 the law was enacted, and probably doctors and patients at first sort of wanted to see how that would work out and how that sort of evolved, and therefore there was some hesitance probably in 2005, but we feel that that is now probably the outlier and that numbers have risen steadily. What is also stunning maybe to an audience like yours is that, I mean, I said that the law became in effect in 2002, right? And so you may be wondering, okay, and so you had a lot of that going on before there was a law, right? That's something that could strike you as well. And that's true, but that's, I guess, to a certain extent the way it works. If there is case law that says that under certain conditions it will be allowed, then indeed at that moment the practice is tolerated to a certain extent, and so doctors, although they could not be completely legally certain about let's say the acceptability of what they did, still they could be fairly certain that indeed they would not be prosecuted even before the law was there. But the strong reason for having a law, of course, was to provide doctors with legal certainty that what they did was indeed, if they stick to the criteria, was indeed tolerated under the law. And that's, I guess, one of the reasons why we have had a law since 2002. Okay, some more numbers, and the colors of the bars will not change, so you may start to remember the colors and see where things come from. Because this is euthanasia and assisted suicide, this is pretty much the same, but in this year we added the purposefully stopping of eating and drinking by a person in order to, in a way, create your own death or to commit suicide. You could all say that. So what we saw is that there's also, I mean, this is all medical decisions about the end of life, but there's not just medical decisions about the end of life, there's also patient decisions about the end of life. So patients sometimes say, well, if you don't do it, dear doctor, then I'll do it myself. And you can do it in various ways, of course, and one of them is by stopping eating and drinking. So it was actually in 2010 that we first started to measure that, and this was the frequency we found. Maybe to give you a little, I said it already, right? I said there was 140,000 annual deaths, so 1% is 1,400 people, right? So 2% is 2,800 persons dying because of this. Yeah. Okay. This, of course, is a very problematic slide. Yes, this is problematic. Am I happy? No, not at all. I'm only happy with the downside slope. But when we first came across this figure in 1990, they have become known as the 1000th of Remmelink, which is a bit unfair because he had nothing to do with it, of course. But anyway, the 0.8% at that time amounting to 1,000 persons indeed ended their life with a doctor saying, yes, I did provide a drug with the explicit intent to end life, but not on request. So yes, that happened as well. And we were very uncomfortable with this. And indeed, it went down, that's the good news. But still, there is a considerable amount of that going on. I can give you information on other countries. You'll see that they have far more than we have in this respect, but that's not an excuse, of course. Doctors tend to do, apparently, sometimes, to act without explicit request of the patient, but they can sometimes use drugs with the intent to end life. And again, this is not tolerated in the Netherlands, but it happens, and we are here to show what happens. So we also have to show, let's say, the problematic side. Right. Again, we could talk more about that. I'm not going to go over all end-of-life categories because it's that would be far too much. You can see how also these studies evolved, because in 1990 we didn't study palliative sedation as an entity. It wasn't much. It was used, but it wasn't much discussed. So it didn't occur to us to include it in our survey. We started doing that only in 2001, and you can see that there is a considerable practice going on. By the way, this is pretty normal. I would guess that on figures upper, so 8-10%, this is 12, can be found in many studies, not of the Netherlands, but internationally speaking. So palliative sedation is used pretty much, and also in the Netherlands. Some more statistics, and then I'll stop. I'll put all of these together. I'm not rushing, but I'm just trying to get to the more interesting part, maybe. So this slide needs a little explanation. What it shows you is that of all people on whom euthanasia was performed, slightly over 20% was 80 plus. That's what it says, right? So of all people with euthanasia, almost 80% cancer. And of all people with euthanasia, almost 90%, the GP was the doctor who performed it. And of all euthanasia, 20%, in 20% of cases, the patients would have a life expectancy of more than 1 month. So most of the patients, 90%, would have a life expectancy of less than 1 month, and probably even close to 1 week. If you ask whether Dutch doctors are very good in let's say, predicting life expectancy, the answer, of course, is no. Probably as bad as Australian doctors, because it is hard. At the same time, well, also in palliative care, you probably are aware of the surprise question, as in, would you be surprised if this person died within half a year or something like that? And it's not rocket science, but it's something that gives you an indication of how close to death that person might be, and that's how we use it. So this is not very strong evidence, but it's an indication of how close to death that person was. Okay. reporting procedure, because I said I would also say something about societal control, right? That was the title of my talk. Medical practice, I've shown you medical practice, and I'm now going over to the second part, which is societal control. Well, the societal control really varied. It started, in 1990, euthanasia was a criminal offense. As I told you, it still is, unless a doctor reports and sticks to the criteria. But in 1990, if someone would report a euthanasia case, police would come to the practice, and that police officer would certainly report to the prosecutor, and a case would be made. This changed into a uniform reporting procedure in which the coroner reports to the prosecutor, and of course the coroner is a medical doctor. So that changes a lot. Rather than having a police with flashing lights coming to your practice, a colleague would come. That makes a difference, right? So the reporting procedure went up. I'll show you shortly. Then in 1998, so before the law, the regional review committees came into being. And I sat on one of these committees for the first 7 years of its existence. And then indeed a law was created, and these regional review committees, RRC, would take the final decision in cases where all criteria are met, and only other cases would be sent to the prosecutor. This slide does not only describe the reporting procedure, but also tells you something of, let's say, the effectiveness of it, because I put here some numbers for the period 2007-2011. In that 5-year period, more than 14,000 cases were reported, and only 36 did not fulfill the legal criteria according to the regional review committees. So these 36 will be reported to the prosecutor, who would then evaluate the case from his perspective, and I can tell you that no physicians in that period were prosecuted. Is that good or bad? Well, we'll get to that later, but it tells you something of how this works. These are numbers again. These are numbers of reported cases. Now please be aware that what I talked about up to now were measured, as in calculated through our surveys, right? So we will claim that the real number is our number. That's what we measured. That is what we have found through this empirical research. And only a portion of that was reported to the officials. And again, as you saw on the previous slide, the official changed over the years. It was the prosecutor, the police, the prosecutor, the committees. So the official person to report to was not the same in all these years, but you can see the numbers of reports rising. It was only last week that the number for 2015 became publicly known. It is 5,517, I believe, and so I've put that in the slide as well. So this is 2014, and this is 2015 already, and I will now show you the very same slide with our measured, calculated, empirically found numbers in it. And from this you can calculate the reporting rate, because we will say that this is what is really happening, and if this is only reported, then the reporting rate is low. And that was the situation in 1990. But remember, that was the time when the police would come with flashing lights to your office if you had the courage of reporting this. And so that didn't really help in terms of reporting. And as you can see, the change in the procedure really helped the reporting rate to go up. In 2005, the reporting rate was 80%. Unfortunately, it remained that. So I should have said it went up till 2005, and then it stabilized at 80% at this moment. I'm very sure that the 2015 survey will show that the incidence of euthanasia has risen, because you can already see that the reported numbers have risen. So probably the real numbers have even more risen. So if 5,500 cases were reported, then it's fair to estimate that around 6,000 cases must have been performed in 2015. That's not a wild guess. That is something that you can expect if you look at these tables. So I said at the beginning of my talk, how am I doing time-wise? And this is okay. So I said that I wanted to show you what's happening. That was the medical practice. I wanted to show you the societal control, and we may have to discuss whether or not that's effective or not. But I also wanted to show you what's changing. And I talked with you about the, let's say, the archetypical case in the beginning of a physician, in a way, coming to the same conclusion as the patient, that indeed it was unbearable and to a certain extent unmanageable. Let's call it that. If you object to that term, then I apologize. But anyway, so that there was really some sort of a necessity in the sense of that really there was a conflict of duties, and the lesser duty was, or it could be reasonable to claim that the lesser of these duties would be to preserve life. The situation in which we are now is a little bit different. You can see that the cases have risen. At the same time, it's rather unreasonable to expect that the quality of Dutch healthcare has fallen, right? So something else must have happened. It can't be that all of a sudden palliative care has become too expensive or inaccessible or gone. It's still there. It's actually improved. That's the funny thing. Dutch palliative care has improved due to the situation, due to the euthanasia discussion. To a certain extent, the 1,000 of Remmelink have really helped us a lot, because I mean, at that moment, before that time, Dutch ethicists and physicians would travel around the world and say, well, no, nothing is happening. If something is happening, it will be on request. And then all of a sudden, there you have them, 1,000 cases without explicit request. Big problem. So a lot of critique, and rightly so. And therefore, the government, really also the government in the 1990s and in the early 2000s, they have put a lot of energy into palliative care. And I can tell you that there was a recent ranking of palliative care in Europe, and we came out 4th. And I believe even above Britain. But I'm not sure about that. But anyway, I mean, 27 countries, we came out 4th. So it's not as if palliative care is, or a lack of palliative care is the problem in the Netherlands. So what are we discussing? What is happening? Well, the patients with dementia, that's a big issue. Again, very interesting subject to talk about. It's interesting to know also that up till, let's say, a couple of years ago, the physicians in the Netherlands, the Royal Dutch Medical Association, has actually been a supporter of the changes in law. This might also interest you. In many countries, as in Switzerland, for instance, there's a considerable, small, but a considerable practice of assisted suicide, not euthanasia, just assisted suicide. But the medical profession in Switzerland is adamantly against. They do not want to have anything to do with it. In the Netherlands, the medical profession have supported the changes in the law, as I described them to you. But with demented patients, for the first time, they've said, we really want to be able to discuss the request with the patient also at the last moment. So not just a piece of paper talking to me saying you should kill me if such and such happens. So physicians are becoming a bit more reluctant than the law actually allows. So physicians would say, if you want to have euthanasia because of dementia, well, we can talk about it, but we need to talk about it. And it wouldn't be possible for physicians to do that just because of a written statement and advance directive. Psychiatric patients, I also told you what happens, right? I showed you the numbers behind there. Of course, they're not from our survey. They're from a different source. They're actually from the annual report of the review committees. So you can check all this. It's happening. But at the same time, it's also discussed. So it's happening, but it's not as if this is normal. Psychiatric patients, it's always more difficult to be certain about prognosis in psychiatric patients. Some say depression is actually a self-limiting disease. Well, probably not in all cases, but to a certain extent, it's harder to tell the prognosis of a psychiatric patient than when you have an end-stage cancer. So that might be a problem. And people who do not have serious medical conditions, but who have grown to be 90 plus, and who sometimes claim that they have been forgotten by death, and they want to step out. Yeah. That's a discussion as well, because you can see, I guess you can see where I'm heading, right? That the medical necessity, if you, I mean, you can say, well, there never ever is a medical necessity, or maybe you can say you're wrong about that. But even if you think that, you can still see the change. That let's say in the 1990s, it was thought of as something that was really a medical necessity to a certain extent, and in a certain interpretation of that. But things are changing. Things are becoming less medical necessary in a way. They are older people without a serious medical condition. So how medical necessary could that be? Answer is not. There is no medical necessity in that case. Probably you hardly see that person. Maybe a little stiffness in the joints, and that's everything, right? So things are changing. And that, of course, leads to a question, what is the role of the physician? I mean, as I said, the law and the jurisprudence was based on autonomy and compassion. That's where this medical necessity comes in. And indeed, that means that doctors have to evaluate the suffering of the patient. And to give you some background information, in 2010 there were more than 13,000 requests for euthanasia, and only 4,000 got performed. Well, maybe you will say, only, too much. But still, I mean, it means that a lot of people got no. And of course, these people who got no as an answer felt disappointed, rejected, neglected, whatever. Which is, in a way, what also explains, to a certain extent, this is not very clever of me. Took me too long. Sorry about that. Here, but this is the slide. Because this group, of course, are the people who say, well, if you do not fulfill my request, then I will take matters in my own hand and I'll stop eating and drinking. And by the way, I do want you to provide medical care during that period, which may create a medical or an ethical problem in itself. So anyway, the question is really, what is the medical role at this moment? Getting there, right. There is no obligation for physicians to perform euthanasia or assisted suicide. If you are a conscientious objector, of course you do not have to do this, certainly not. Yet I would say that the role for a medical evaluation of suffering becomes smaller. And that indeed we are, in a way, moving towards a situation in which it's really only autonomy based, whether or not the request is fulfilled. And one development is well, probably not responsible on its own, but this is both a sort of a catalyst and a sign of this process. So it's both a cause and a product of the process that I'm sketching. I'm telling you that euthanasia started out on two grounds, right? Autonomy and compassion, and it's moving towards a situation in which it's primarily autonomy based. And again, both a sign and a sort of a motor, a catalyst in this respect is the end-of-life clinic that started in 2012. And it's a clinic where doctors work, and you can go there. And if your own doctor said no, so one of these 13,000, what was it? 13,000 minus 4,000, so one of the 9,000 could go there and say, well, my own doctor doesn't want to do it, can you help me? Now, legally speaking, I didn't tell you there were two laws, right? I mean, there's just one law. So legally speaking, they of course have to abide by the same law, of course. But they interpret the conditions liberally. And ever since the review committees upheld those cases and accepted them, that has now become the more liberal interpretation of these conditions, because the committees have accepted that interpretation. So indeed, this end-of-life clinic has performed euthanasia in a number of cases where you might have questions, certainly in terms of that dual justification. So indeed, this is not just because of the end-of-life clinic, but the consequence of all of this is that there's less role for medical evaluation in the current euthanasia practice in the Netherlands. So I guess my concluding remarks have been said already. Society tends to focus more on patient autonomy, doesn't accept evaluation of the suffering by a physician that much anymore. Is that good or bad? Well, that's really where probably the two groups in this audience diverge. Some will say, no, this is good. This is good because you have any place in that evaluation at all. It's the life of that patient, not your life as a physician. So why would you evaluate that? So you would say, well, finally, this is coming to, let's say, maturity of this practice. Get the doctor out of that evaluation. That could be a position. I'm not telling you what position to hold, but it could be a position. Others would say, no, really, this something is happening. We started out with euthanasia-assisted suicide being, let's say, an ultimum refugium in Latin, so an ultimate option. So what's the right word? You know what I mean? It's sort of the ultimate thing you can do under duress, in which you have only bad options to choose from, and you choose the least bad option. I mean, that situation, that's how it started out. And it has become something else. It has become an option to prevent suffering rather than to sort of, well, take care. I don't know, again, if that's the right English word, but still. So it has become something else. And whatever you say, whether you respond that this is good or bad, in both cases, there is a new discussion on the role of doctors in this. And I think Australia or South Australia may not want to go in this direction at all, and please don't if you don't. I'm not here to persuade anyone. It's just that if you do set up something, Canada, of course, is right in the midst of doing that, right? Canada, after that famous High Court case they had 2 years ago, they have now been obliged by their legal system to come up with a system. And it's vital to think about the role you give to doctors in such a system. Do you want them to be evaluators of the suffering? Well, there are good sides and bad sides to that. Or do you not want to have that and just want the doctor to be there because he knows his way around drugs? If that's the case, you'll have a complete different situation than when you, as we did when we started, when you put the doctors in the role of the evaluator of suffering. Now, there's much more to say, there's much more to tell, but I have already used more time than I was actually given. So my apologies for that, and here I would like to stop.
Thank you very much. Excellent presentation. So there is now some time for discussion indeed.
Less than I hoped, probably.
Yeah, please.
Thank you very much. I'm a urologist.
Right.
So I deal with many diseases that are incurable.
Yeah.
But my question, I guess, is there's two parts which are interrelated. So one is more of a philosophical one. What's unique about the Netherlands that it should be one of the first to do this? And the second is more practical related to that. So just in thinking briefly, there's three groups that I see. One is the population, the layperson. One is, say, politicians or the lawmakers, and the other is, say, doctor groups.
Right.
In the Netherlands, which group really pushed and lobbied hard for this? Or was it a combination of things? Or
Yeah.
I'm interested just in how it...
Yeah. Okay, so the first question is a very, thank you for those questions, by the way, but the first question is really an obvious one, to which I have no obvious answer. Actually, Annette just asked me the same question this afternoon, and we have tried, we've written an article, which isn't even published, but we don't really have a good answer. I mean, I could give you the story about the Golden Age and how tolerant the Dutch were and all that. But it's probably not true. Well, it may be true for the Golden Age, but not for later times. The Dutch were pretty backward in a way. I mean, yeah, if you were Protestant, you would go to the Protestant grocer and the Protestant dentist and the Protestant doctor. And if you're Catholic, you had your own grocer and your own baker. And so not really enlightened people. And yet, something happened. And so I think a number of things. And in part, connected to the second part of your question, that indeed at some point, both the medical association and the public, supported by the first legal case, accepted this idea. And even the churches stepped in, not the Catholic Church, but the Protestant churches, they really supported this idea. But of course, they supported what I tried to sketch with that medical necessity thing, right? So the idea that at some point, indeed, if you are in a conflict of duties, the duty to relieve suffering may count as the stronger one. But you would have to be in that conflict of duty situation, right? Which, in my estimation, is sort of fading away right now. But that's how it started, that's how it was framed, and that's how it was supported also by the Dutch church, the Protestant church. Why is this? Well, to a certain extent, I think this is coincidence. I really think it is. In the US, you had Karen and Quinlan. So everyone talked about stopping ventilators and PVS and withdrawing treatment. And we had our case in 1973, and so everyone talked about that. And the Dutch Voluntary Euthanasia Organization was created in 1973. And so that was our famous case. And of course, it was also a time when there was widespread criticism on the medical system. There was criticism on everything. Every, let's say, settled profession would be greeted with criticism, and also, of course, the medical profession. And this was our way of expressing that criticism. And in other states, they might have taken a different route. But the real answer to your question is, I don't know. Yeah, sorry about that.
Good sort of question. I've got to hear first of all.
When Rob Jonquier was here visiting us,
Yeah.
he impressed upon us the importance of that word unbearable.
Ah.
And we have employed that word quite freely and easily. And that word should come from the patient means that the whole business is patient-centered. Now, when we come to talk to the parliamentarians, this word unbearable comes from the patient and nobody else. Seems to stick in their craw, and they seem to want to actually break down unbearable in a whole series of conditions, part of which my friend over there deals with, none of which I deal with because I haven't rendered anything in gynecology. I'm speaking on the same page. So they have difficulties in accepting that a patient can say, this is unbearable, full stop. Quite simple. Not complicated at all. Do you have any advice for patients?
Well, I know Rob de Jonquier quite well. I mean, even if we are not always on the same side, let's say the people who are busy and studying and exploring euthanasia all know each other and work together. So I know Rob de Jonquier pretty good. And I agree with him that unbearable is a very important word. I disagree with him if to say that it's the only word. And so the full stop, as you put it, would not be mine full stop. So I would argue that in the beginning, as I have argued, there were two legs to stand on. Not just the one of the patient claiming it was unbearable, but actually also the medical evaluation saying, I cannot do anything about it. I can even show you writings by Kuitert, you may have heard that name, famous ethics professor in the 80s in Amsterdam, who even claimed that that was actually the more important thing. So I would say this is probably where some of you diverge, indeed, because you might be someone who says, well, it's good that you're finally getting rid of the medical evaluation of the suffering, because finally you're doing what it had supposed to be doing, you had supposed to be doing all the time, which is leave that evaluation to the patient. And so then you would never have any appreciation for medical judgment in this area. And I'm only claiming that there is a shift. that it used to be different, and that nowadays it's more autonomy-based than it used to be. That's what I'm saying.
I'm conscious of lots of hands going up, and I anticipated that, but I am conscious also of the time, and some will have to get away. I think probably a couple more questions, then I think if you're happy, then other questions perhaps after we conclude. But yes, the first one up there.
Thanks for an excellent, I think, very balanced presentation on the issue. I guess all of the discussion with euthanasia starts with these cases of unbearable suffering, where everybody agrees that it's a terrible sort of situation.
Yeah.
But then once the logic that actively causing death is an acceptable response to suffering is accepted, then we see sort of this gradual expansion.
Yeah.
And indeed autonomy, I guess, is not even the full requirement in the Netherlands with child euthanasia, for example.
Okay.
Although that could be debated as well. And we see this expansion over time. Where do you see the end point, so to speak, of Dutch euthanasia?
Okay, that's a hard one, a tough one. First of all, I agree with you very much. I mean, there's several angles of approaching this subject, and indeed, it is vital to discern between an individual case, a hard case, in which anyone might say, well, yes, okay, I see the justification, and a policy. It's quite something else to have a policy than to accept euthanasia in an individual case, right? And so what I'm showing you is the effect of having a policy. And I guess it makes a difference. We started out with having hard cases, and they were judged by judges in court cases. And I guess that was also the reason why the churches were actually supporting it. And then later we created a policy. That's the law. Where does this end? I'm not sure. I'm not sure. It could mean that doctors at some point feel, well, sorry, if we're here only to do the technical part, then no thank you. Could be an option. Or that only some doctors, I don't know how that works in Australia, but in my country, only some doctors perform abortion, for instance. And let's say the ordinary doctor doesn't have to sort of make up his mind about abortion. It's never ever in his practice. So maybe in 10 years, 20 years from now, this is something that will be performed only by some doctors who really believe in unbearable full stop, as you put it. Whereas others will say, well, not my cup of tea, no thank you, this is not my habit. Dutch doctors are very much like other doctors. They want to cure patients. I mean, again, I've been a doctor for 25 years. Practicing, I'm still a doctor, but I've been a practicing physician for 25 years. Of course, that is your job, right? So I'm not sure where this ends. But I do see, that's also what I hinted at, I do see for the first time in many years a divergence between the policy and the stance of the medical profession. Yeah.
One last question from Hubertus.
Yeah, about 15 years ago, we had a Euthanasia Act in our version of the Netherlands in Northern Territory.
Yeah. I think it's a bit drier there.
But that was actually physician-assisted suicide.
Right.
It was called euthanasia.
Yeah.
And they had a third tier of a mandatory psychiatric assessment to allow for mild depression, hidden depression, and this kind of mental conditions which were obviously psychosis. I noticed that that's missing in the Netherlands.
Well, actually it's not. No, but I mean, there's so many details that I could go into. But if there is a psychiatric illness, you have to have a psychiatric extra independent review of the case.
If it's mild depression?
Yeah. If there's mild depression, you would probably be advised as a doctor to get a consultant psychiatrist to look into the case. Again, I've been on an assessment committee or a review committee for 7 years, and as soon as we came across an antidepressant, we would say, what happened? Tell me. So, yeah, in a way, there is this requirement that in those cases you would have an extra consultation. Yeah.
Well, thank you very much. I mean, just by the number of hands that were going up, there's a lot of interest, clearly.
Thank you.
And I'm sorry that we don't have enough time to go through all of those questions. But Hans, thank you very much for a really stimulating presentation on what is clearly a hot societal topic. Yep. Irrespective of what people's individual stance is on the debate, there's no doubt that the evidence, the experience that you've had in the Netherlands provides an evidence base, a very rigorous one, that should allow other jurisdictions, other countries, to have a serious consideration around this. Right. So thank you very much. I've got just a little gift to remind you of your brief stay in this lovely part of the world, and hope that you come back.
Well, so do I. Thank you very much. Okay, thank you.
Thank you all for attending. Have a safe journey home. Thank you. That was great. Really good.
I'll put this out off.
Yes. Yeah, very good. Yes. Yes. Fantastic.
I did want to be
Yes.
I guess you can tell that I'm on the second class. I don't think this is a good development, but I didn't want to say that.
Sure. Yes.
I'm Dutch. You speak Dutch as well, right? Ja.
Of course.
Ik vroeg me af. Ik heb de documentaire van de Dodenkliniek gezien. En dat is
die heb je gezien.
Een heel groot controverse. Maar wat ik dacht is, heeft dat niet ook... Of ja, misschien dat het nu nog een beetje goed is. Maar wat mij heel erg opviel, mijn opa heeft de euthanasie aangevraagd en gekregen. Maar dat zijn mensen die hun hele leven naar dezelfde huisarts willen gaan. Dus je legt heel veel vertrouwen in je huisarts. Maar mijn generatie bijvoorbeeld, wij verhuizen constant, veranderen de hele tijd van huisarts.
Ja, en jij niet alleen, maar de huisarts ook. Want de oude huisarts die je hele generatie kende, die bestaat helemaal niet meer.
Ja, die bestaat niet meer. Mijn opa zat 40 jaar bij dezelfde.
Ja, nee, die bestaat gewoon niet meer.
Maar denkt u dat dat dan ook samen gaat hangen met de manier waarop het
vast. Ja, vast. Ja, vast. Je hebt gewoon gelijk, ja. Maar wat vond je van die documentaire?
Ik heb het idee dat het heel slecht geëdit was. En dat het heel erg een controverse uiting was. Maar ik weet het niet zeker.
Ik vond hem super schokkend.
Ja, want ik ben heel erg... Ik zie mezelf als heel liberaal. En zeker als een voorstander van een euthanasie. Niet dat iedereen euthanasie moet plegen. Zeker van de wet. Ja. Maar ik vond hem vrij... heel op het randje.
Ik totaal over het randje. Ja. En die documentaire die creëert heel veel turmoil. I'll come over here so everyone can hear, and we should switch back to English maybe. Because